Hello, everyone. I'm sorry I can't be there in person this year, but we'd like to share a recent presentation you had at the European Stroke Organization called the Attention Trial. It's the first level 1 evidence for basilar artery thrombectomy. It's a trial that I collaborate with this attention group in China, and start by providing you some background. Here are our disclosures. So basilar artery occlusion was actually the first territory to be investigated in the contemporary times in terms of intra-arterial treatment. The first report of endovascular treatment of stroke was actually Sussman and Fitch in 1957. They inject intra-arterial plasmin to treat 3 strokes in the carotid territory. But between the late 1950s until this report in late 1980s by Professor Hake and Hermann Zillmer, nothing much happened. And in this report of 43 patients treated with intra-arterial thrombolytics for basilar artery occlusions, they did a case control comparison and saw very significant improvements, as you can see here. Having said that, despite the overwhelming benefit of endovascular treatment to treat anterior circulation strokes, still remains unknown whether thrombectomy is beneficial to treat acute basilar artery occlusion. You have the Herculean efforts of the BEST trial in China and the Basilar BASICS trial out of Netherlands, but with participation of other European centers and also my home country, Brazil. And unfortunately, those trials were inconclusive. They had many issues with problems with equipoise, in particular the Chinese trial for which I was one of the co-PIs. We had a lot of problems with crossover. So what happened is when the 2015 trials came out and they were so positive, physicians start to get uncomfortable randomizing patients to no treatment. So we had to finish the trial at 130 patients, and we had over 20% of the control patients going to the thrombectomy arm. Despite that, we still had a 10% treatment effect size. And in the as-treated analysis and per protocol analysis, the trial was highly positive, but it failed to achieve a positive result in the intention to treat analysis. The BASICS trial, as many of you know, it was a trial that took a long time to complete, over 8 years to enroll 300 patients. And basilar artery occlusion is responsible for about 10% of all large vessel occlusion. So it's less common, but it's not that rare that it should take 8 years to enroll patients. So it became clear in the paper that about 1 out of 3 patients were being treated outside the trial, and the majority of those, over about 80%, were receiving thrombectomy. So there was, again, a selection bias due to less of equipoise. But the importance of this is very much you had IMS3 synthesis expansion and MR rescue in 2013 with those negative results, right? It kind of paved the way for the 2015 trials. And that's kind of what these 2 trials did for the Attention trial and another trial called BIOCH. They kind of paved the way by reestablishing equipoise, at least in China. Moreover, they help us identifying the target population. We always knew that basilar artery occlusions with mild NIH stroke scale didn't have quite the same treatment effect size, but I think BASICS really highlight on that. In the BEST trial in Japan, we only enroll patients with baseline NIH stroke scale equal greater than 10. So at the ISC last year, we presented the Veritas analysis, which is individual patient level pool analysis of BEST and BASICS with the target population of NIH equal greater than 10 at baseline. As you can see here, the results were statistically significant in terms of benefit for thrombectomy. That happened despite a significant increase in the rates of symptomatic intracranial hemorrhage, but there was an absolute risk reduction of 12.2%. Not only that, but we also helped conducting large basilar artery thrombectomy registries in China. And the first one was the Basilar group registry. We had about 830 patients, and then both in the overall comparison and also in the propensity score matching comparison, we could see here very significant benefit for more favorable outcomes with thrombectomy versus control. But again, even though these were prospective studies, they were not randomized, so we still can have selection bias. We then also the attention registry, that's a different group in China, much larger study, probably the largest, actually definitely the largest thrombectomy for basilar artery occlusion registry ever done, with over 2,100 patients, okay? Out of each, about 1,600 had EVT and just over 450 best medical treatment. So we did adjusted analysis with IPTW and propensity match score, and the results were very consistent. So when you look at table 2 here, you can see that the primary outcome, that was MRS 0 to 3, was statistically significant, more common with thrombectomy than no intervention treatment. You also can see that any shift in MRS was more common with thrombectomy than no interventional treatment. Function independence also more common. Mortality was actually lower with thrombectomy than with control best medical management. And again, this happens despite an increase in the rates of symptomatic intracranial hemorrhage in the thrombectomy arm. So now we have a patient level pool analysis of 2 randomized trials and 2 very large registries that were prospective, consistently showing potential benefit. Okay, and I really want you to remember this, right? MRS 0 to 3 significant, shift is significant, 0 to 2 is significant, mortality is lower, and there is obviously an increase of symptomatic intracranial hemorrhage that has been very consistent. Please remember this. This is the registry, over 2,000 patients, as you move now to the randomized clinical trial. So you transition from the registry to randomize these patients. The absolute mandate here was that you could not treat patients outside the trial, and you had to enroll all consecutive patients. The objective was to demonstrate that endovascular therapy was superior to best medical treatment in achieving favorable outcomes. That's defined by an MRS 0 to 2 at 90 days in patients with acute basilar artery occlusion within 12 hours from the estimate time of basilar artery occlusion. Study methods, very typical, screening. And again, the patients had to come within 12 hours. They had to have age equal greater than 18, baseline NIH stroke scale equal greater than 10. If they were younger than age 80, MRS could be up to 2, but if they were older than age 80, we require an MRS of 0. So you treat the elderly, but the only, the good elderly that doesn't have much disability, because we know that this population is more susceptible to worse outcomes. So we then did imaging to confirm the presence of a basilar artery occlusion on CTA, MRA, or conventional angiography, and parenchymal image to exclude intracranial hemorrhage, as well as identify patients with strokes that weren't very large, defined as, for the younger patient, a posterior circulation aspects of 6 to 10, but for the patients that were older than 80, a posterior circulation aspects that were 8 to 10. We then randomized the patients in a 2-to-1 manner for either thrombectomy or best medical treatment, which could include intravenous TPA if the patient show up in the first 4.5 hours, and as a standard, follow the patient for 90 days. The study design was a probe type of study. This occurred at 36 comprehensive stroke centers in China. And the assumption here is that you would have an absolute risk reduction of 15% in terms of outcomes. This gives us a sample size of 342 patients after a 5% attrition and 80% power. Study endpoints, we already discussed the primary endpoint, MRS 0 to 3 at 90 days. The secondary endpoints, very typical for these studies, including functional independence at 90 days, 0 to 2, and ordinal shift analysis, as well as evaluation of NIH and AeroQual. Safety endpoints, so we look at mortality at 90 days, symptomatic intracranial hemorrhage, and procedure complications. So move on to the results. So I think the first thing that stands out is that Basics took over 8 years, right? Over 8 years to enroll 300 patients. In less than 1 year, we could enroll 342 patients. And the reason is not only that these are huge hospitals, some of these hospitals in China having 5,000 to 7,000 beds. So these are very high volume centers. But the main reason why this happened is actually the fact that we treat outpatients. So out of 507 patients that we screen, we exclude 165. The main reasons for exclusion is because they didn't meet either the inclusion or they met an exclusion criteria. But there were only 24 patients that declined participation in the trial, and those patients were not treated. Okay, so no cherry picking. We then randomized 226 patients to intervention, 114 patients to control, 2-1, and none of the patients were lost to follow-up. There was very little crossover, as you can compare attention here with Basics and Best on both arms. Baseline characteristics were well balanced. The median age was around 67. The median baseline NIH stroke scale very high at 24. The median PC aspects was 9 intervention and 10 in the control, but not statistically significant difference. And about 1/3 of the patients receive intravenous thrombolysis, okay? In terms of time metric, the time from stroke onset to randomization was about 5 hours, right? So about half of the patients, right, were randomized after 5 hours and treated probably after 6 hours. When you look at the comorbidities, everything was well balanced. I want to point out here that about 20% of these patients had atrial fibrillation, which is just like what you had in Basics, okay? Another 20% had diabetes, which is very similar to Basics. But what is different, since this is an Asian population, is the incidence of large artery atherosclerosis. About 40% of the patients or so, 45% had large artery athero, with about 40% of them being intracranial and 5 to 8% being extracranial athero. Endovascular treatment, most of the patients receive combined technique with stent retrieval or aspiration. About 1/3 receive aspiration only. And the use of intracranial angioplasty stenting was common at almost 40%, with extracranial angioplasty stenting typically divert origin in about 8%. Recanalization was very high at 93.3%. And here is the primary endpoint, okay? So you can see thrombectomy, you can see best medical management, 22.8% of the patients achieve 0 to 3. Double of the patients achieve, 46% achieve 0 to 3 with thrombectomy. So this translates in an adjusted odds ratio of 2.1. Okay, and a highly statistically significant p-value of 0.001, with a number needs to treat of 4. So very much like the best anterior circulation trials. So what I'm trying to say here is, as long as you design a trial well and you don't allow for selection bias, you enroll all the consecutive patients, you can clearly show that basilar artery occlusion is highly beneficial. How about the secondary endpoints? The MRS distribution had an odds ratio of 2.9 favoring the intervention. Patients that underwent thrombectomy were 3.2 times more likely to achieve function independence at 90 days. And you can see here that all the other secondary endpoints were significantly improved by thrombectomy. When you look at secondary outcomes, imaging outcome, patents of the vessel was significantly higher at 24 to 72 hours with thrombectomy than control, not surprising, 91% versus 38%. More patients have symptomatic intracranial hemorrhage. We talk about that. It's something you have seen in the prior studies and registries. 5.3% with thrombectomy, which is not very far from what you see with anterior circulation. Herm's meta-analysis was 4.7, so very similar, but in the control there was 0, so that's a significant difference. However, death was actually significantly lower with a risk ratio of 0.66 in favor of the thrombectomy patients. So even though you have more symptomatic intracranial hemorrhage, not only you have better outcomes, but you actually have lower mortality. And I think I should point out that the only anterior circulation trial that showed a mortality benefit was the ESCAPE trial. Mistrecline didn't show mortality benefit. Revascat, Resilient, Swift Prime, no other trial other than ESCAPE has done that in the anterior circulation, okay? And when you look at ESCAPE, the benefit really comes from treating the elderly patients, those with old age greater than 80 with thrombectomy. So here in the basilar artery occlusion, it really looks like this is a life-saving procedure. Okay, life-saving procedure. So the complications were pretty standard. You can see here dissection perforation at less than 3%. Here is the subgroup analysis, and you can see that everything has an odds ratio greater than 1 with point estimates that either significant or closely to significance favor the thrombectomy patients. One thing that I want to point out here is this ICAD population, right? Because we had almost 40% of the patients had intracranial atherosclerosis, okay? But when you look at the non-ICAD population, okay, which was over 200 patients, almost 220 patients, the odds ratio of 2 was 2.5, actually, if anything, higher, right? And this was statistically significant. So even though this is Asian and you have more ICAD in Asia, you can clearly demonstrate this effect actually happens in both intracranial athero or non-intracranial athero basilar artery occlusions. So there are limitations. The first one being this issue we just talked about. This is an Asian Chinese study. They have more intracranial atherosclerotic disease. So how the generalizability of that can be applied to Western countries needs to be considered. Okay. But again, in this context, the etiology was thought to be large artery in 45% of the cases, leading to high rates of intracranial stenting, about 40% of the cases, and extracranial stenting, about 8% of the cases. However, if anything, I think we all would agree that angioplasty and stenting is more technically demanding and presumably associated with higher complications than just doing a mechanical thrombectomy. These were patients that didn't have angioplasty and stenting only. Typically, they had a thrombectomy first, then rescue stenting if needed. Moreover, as I demonstrate here, there was a subgroup analysis based on the presence of ICAD, and the patients that did not have intracranial athero had a significant benefit with actually a higher risk ratio. Finally, the proportion of the comorbidities between attention were very similar to the BASICS trial. Okay, I call out the fact that the rates of hypertension, diabetes, atrial fibrillation between the Asian study and the Western study were very similar. So these populations are not that different. So in terms of discussions, in contrast with the previous basilar artery occlusion, randomized clinical trials, namely BEST and BASICS, the attention trial was able to reinforce consecutive enrollment result in fast recruitment while also minimizing any issues of crossovers. Okay. The overall results of attention are consistent with modern area observational studies, including 2 large Chinese registry and the individual patient pool analysis of best and basics. The disability reduction benefit of EVT in basilar artery occlusion appears to be in the same range of what you see in anterior circulation. So let's compare attention with Hermes, which is the meta-analysis, the pool analysis of the early trials, and Aurora, which is the pool analysis of the late window trials like down diffuse and the late patients in the other trials. So here the odds ratio for any benefit is 2.9. Anterior circulation early is numerically a little lower, but similar 2.5, and late window anterior circulation also 2.5. So the benefit, it's actually very similar, if anything, numerically higher, but I'm sure it's not significant. However, in contrast to most anterior circulation trials, as I mentioned, attention also demonstrate a potential benefit in terms of mortality. So aggressive treatment of basilar artery occlusion leads to lower mortality. So to conclude, endovascular treatment of basilar artery occlusion is associated with higher rates of favorable outcomes defined as NMRS 0 to 3, 46% with endovascular therapy versus 23% control, so essentially the double. This translates in a number need to treat of only 4. Also, there is a benefit in terms of function independence, MRS 0 to 2, 33% versus 11%, and overall decrease in disability with an MRS shift at 90 days, odds ratio of 2.9. And for the first time, we see in a more generalized population, right, across our age, a benefit in terms of mortality. So we can finally say that the overwhelming efficacy of endovascular therapy persists in patients with posterior circulation basilar artery occlusions. So I would like to thank all the participants in the trial, the families, my colleagues from the Attention Network. And with that, just before we take a few more questions, I'm not going to go over all the results, but in the SOC, our colleague Tudor Joving present the BIOCI trial. And I just want to highlight BIOCI was very similar to Attention. What is the big difference? 6 to 24 hours. So Attention was 0 to 12 hours, BIOCI 6 to 24 hours. Okay, they had to use solitaire. We did 2-to-1 randomization. They did 1-to-1 randomization. They were supposed to enroll 318 patients, but stop at the first interim analysis for early efficacy at 212 patients. And the eligibility criteria was very similar, other than, again, 6 to 24 hours time. And I just gonna go straight to the results here. Overall, the baseline characteristics were very similar. You can see here medical history, very similar, high PC aspects, so favorable imaging in these patients. The location of basilar artery occlusion, you see that proximal is common. You know, proximal, you have more atherosclerotic involvement, right? So again, it's an Asia study with high incidence of large artery atherosclerosis, as you see here, being an Asian study. When you look at the safety endpoint, so you can see that the risk ratio is less than 1, right? Therefore, mortality was numerically lower, thrombectomy 31% versus best medical management 42%. So there was almost a 11-12% reduction. And that approached statistical significance. It wasn't like in Attention, that was statistically significant, but the P is less than 0.10. I bet if they had enrolled the 300 plus patients they should have enrolled initially, then this would be statistically significant. Again, the rates of symptomatic intracranial hemorrhage higher in thrombectomy than in the control, but around 5 to 6%, very consistent, right? And the rate of PH is a little higher, but again, consistent with that same ballpark of about 5%. Here is the primary analysis, okay? And in the adjusted analysis, patients that underwent thrombectomy were 1.8 times more likely to achieve an MRS of 0 to 3 at 90 days. So 46%. Remember, in attention, the number was exactly the same. The number was 46% for thrombectomy. And the best medical treatment here, okay, did a little better because these are probably more like slow progressor patients. So 24% good outcome in the control. So again, very similar to what I show you. This is the attention comparison here. So very consistent. MRS 0 to 2, statistically significant with an odds ratio of 2.8. Ordinal shift analysis, statistically significant with an odds ratio of 2.6. Okay. And this is actually an interesting finding. They look at thrombectomy and the outcomes of thrombectomy. So solitaire device was used in 93% of the patients, aspiration, very few patients, less than 3%. And in about 37%, right, they actually stent the patient, very similar to attention at 40%, mostly using a detached solitaire in 68%, other stents in 32%. But the nice thing is there was no kind of difference between the patients that had stents and no stents. And you can see the subgroup analysis again showing very much like what you saw in the earlier window attention trial, how the point estimates favor thrombectomy. So I think the conclusion here is that we now have two studies, attention in 0 to 12 hours and BIOCHI 6 to 24 hours, showing the dramatic improvement of thrombectomy in the basilar artery occlusion territory. The caveat is that both are Chinese studies, but then when you exclude patients with intracranial atherosclerotic disease, which we still see in Europe and the United States, right? It's just less frequent. The results are still significant for patients that had embolic occlusions. So I think this is very important. Most of us knew this, most of us were treating these patients aggressively, but now you can finally go to families, right, and tell them we must do this because you have level 1A evidence from 2 randomized clinical trials demonstrate a dramatic benefit in this patient population. Thank you very much for your attention. I'll take any questions.